So today we'll begin a simple primary care review on preeclampsia in pregnancy. Preeclampsia is a multi-system progressive disorder. Preeclampsia is characterized by the new onset of hypertension and proteinuria, or the new onset of hypertension and significant end organ dysfunction with or without proteinuria after 20 weeks of pregnancy. The mother and child are at increased risk for serious morbidity or mortality. The most effective treatment is the delivery of the baby. Causes of preeclampsia. It is caused by multiple factors, which include placenta and maternal vascular dysfunction. Preeclampsia risk factors include multiple pregnancies, such as twins, teenage pregnancy, advanced maternal age over 35 years old, overweight or obese, placenta insufficiency, such as fetal growth restriction, abruption, and stillbirth, history of a past preeclampsia, history of diabetes mellitus, history of hypertension, history of kidney disorders, or history of systemic lupus erythematosus. Screening preeclampsia includes measuring blood pressure at the first prenatal visit to establish a baseline, continuing to screen for preeclampsia by measuring blood pressure at every visit, screening the risk factors at the first prenatal visit, performing a urinalysis to test for proteinuria at the first prenatal visit, continuing tests for proteinuria at each prenatal visit, and you would treat high-risk women with high low-dose aspirin throughout pregnancy. The clinical presentation: hypertension and proteinuria. It is the earliest clinical findings and the most common clinical presence of the disease, where 85% of patients present with new onset hypertension and proteinuria at greater than or equal to 34 weeks of gestation. 10% develop hypertension and proteinuria at less than 34 weeks of gestation. And 5% of preeclampsia cases present at postpartum, usually within 48 hours of delivery. Epigastric or upper abdominal pain. It is a severe disease spectrum which may radiate to the right hypochondrium or back. Nausea or vomiting sometimes can occur. The liver may be tender to palpation. Liver rupture or hemorrhage should be suspected when there is a sudden onset of right upper quadrant pain associated with a decrease in blood pressure. Headaches. Persistent throbbing or pounding headache despite administration of Tylenol. It is the symptom of severe disease. Visual symptoms include blurred vision, photopsia, and scotomata. Visual disturbance is a symptom of a severe disease. Stroke. Stroke may lead to death or disability. Most strokes are hemorrhagic and presented by severe headaches and severe fluctuating blood pressure levels. Seizure. Eclamptic seizures can develop without severe features. It may cause brain hemorrhage, petechiae, edema, vasculopathy, ischemic damage, microinfarcts, and fibrinoid necrosis. Pulmonary edema. Pulmonary edema is more on the severe end of the disease spectrum. The symptoms is a complex of dyspnea, chest pain, and or decreased oxygen saturation through the pulse oximetry. Oliguria. Women with preeclampsia commonly have transient oliguria which is less than 100 milliliters over 4 hours in labor or the first 24 hours of postpartum. Peripheral edema, sudden and rapid weight gain, which is greater than 5 pounds per week, and facial edema are more common in women who develop preeclampsia. Abruptio placentae. Abruption can be a life-threatening event for the mother and fetus. Laboratory tests. CBC. A platelet count of less than 150,000 microliters can occur. Elevated serum creatinine levels of greater than 1.1 milligrams per deciliter indicates severe disease. Liver function tests include AST and ALT. A urine study of greater than or equal to 0.3 gram proteins in a 24-hour urine specimen, as well as a random urine protein to creatine ratio of greater than or equal to 0.3 milligrams of protein per milligrams of creatinine. Coagulation studies are not routinely ordered, but are obtained for complications such as abruptio placentae, severe bleeding, thrombocytopenia, or severe liver dysfunction. Fetal status assessment, non-stress test or biophysical profile, ultrasound to evaluate amniotic fluid volume and estimate fetal weight, umbilical artery Doppler, increased impedance to flow in the umbilical arteries indicate uteroplacental maldevelopment. Fetal complications. For the fetus, preeclampsia can lead to growth restriction, oligohydramnios, and preterm birth. Perinatal morbidity and mortality are increased, with the highest risk in pregnancies with onset of preeclampsia before 34 weeks of gestation. Thank you.